everyone. Thank you for joining us for this podcast. We're going to talk about preventing clinical decompensation in patients with liver cirrhosis and clinically significant portal hypertension. Today, I'm joined by Dr. Steven Flamm from Rush University. Thank you so much for being here.
Thank you, Marcelo.
We just finished the section on cirrhosis and portal hypertension, and you gave a fantastic talk on portal vein thrombosis. So how about if we go over it a little bit and discuss what was important during this meeting? We presented a case of a patient that presents initially with alpha-1 antitrypsin deficiency, known lung disease, and he comes to a hepatology consult. And there was a problem with a little bit of anchor bias in that the hepatologist didn't quite address other potential etiologies of liver disease, like MASLD at the beginning of this case. And then this patient went on to develop cirrhosis and get worse over time. So how about if you share with us what are the things that you look or that you ask of the patient when they present to try to rule in or rule out advanced liver disease? We have this new concept of compensated advanced chronic liver disease, not obtaining liver biopsies. What do you do initially with these patients?
Well, first of all, Marcelo, this case illustrates a very important point, I think, for the viewers. And that is you cannot make assumptions when you see a patient with chronic liver disease. You cannot assume that a patient has only one diagnosis for their liver disease. Many patients have more than one. And when I see a patient with liver disease, even if the diagnosis appears obvious, they drink 12 beers daily, I do a full workup to rule out other possible causes of chronic liver disease also, in every one of them.
Right.
I send everything. I'm a hepatologist. People that are viewing this are gastroenterologists, hepatologists, providers that take care of these patients. I rule out viral hepatitis. I rule out concomitant autoimmune hepatitis. I rule out alpha-1 antitrypsin deficiency. So I think it's a very good idea when you have a patient with chronic liver disease, particularly if they have advanced liver disease, to do a complete workup to make sure you're not missing anything. Even in drinkers or people that you think have fatty liver, rule out other liver diseases. You know, there's a new concept now that's called MASLD. These are people that have both fatty liver MASLD and alcohol-related liver disease, two liver diseases. And unless you think about this and evaluate a patient for this, you are not making the correct diagnosis and you're not making the correct interventions that will optimize their clinical care. So I think, and in my practice I do this, I rule out two liver diseases in every single patient. What do you do?
I do exactly the same thing that you do. I do test for everything that we know how to test and that we can test. And in particular, certain things that I can treat and certain things that I can prevent. So even in the patient with chronic liver disease, I will check for hepatitis A status, because if they haven't been exposed or vaccinated, then I'll want to vaccinate them for hepatitis A. And so I agree with your concept. And then we obtain imaging. And so I wanted to ask you maybe 2 or 3 pointed questions about this. One is, what is your preferred initial imaging method that you use? How often do you think that, or how often will you complement that with a non-invasive assessment of liver fibrosis? What is your preferred method to do that?
Well, you know, when patients come to us, this is true with any cause of liver disease, right? They want to know what they have, they want to know why, and they want to know how bad it is. So it's incumbent upon us, when we get to the bad part, to figure out how much fibrosis there is.
Right.
Now, in the old days, when you and I were young practitioners, we used to do liver biopsies all the time to stage these patients. Now we don't anymore. We use these non-invasive tests. And they're very important, and they should be used in the armamentarium, I think, of all practitioners that take care of liver disease. Practitioners have to become familiar with and comfortable with using these tests to assess how much liver damage patients have. Now, your choices are blood tests or elastography imaging tests. Transient vibration-controlled elastography is a very important means of assessing fibrosis. If that machine is available to the practitioners, I think that's a very good initial test. It's what we use, but I have the machine in my office.
Right.
If I don't have the machine in my office, I do a blood test, and I use either the proprietary tests like the ELF test, the Enhanced Liver Fibrosis test, or the FibroSure test. And if for some reason I don't have either of those, if a patient's insurance doesn't cover it, who knows, then I use a FibRSure, which people have available because you always have those test results that can be used for that. So,
and so easily calculable.
And it's easily calculable.
In a minute.
In a minute. And I do this on every liver patient. And in fact, I not only do it initially, but I do it if a patient doesn't have cirrhosis, I do it to follow. So I use these types of tests, elastography, if I can, to try to assess if a patient has fibrosis and how much.
Yeah.
What do you do in your practice?
I pretty much do the same, but I probably, at the risk of being too basic, I'm going to say that AASLD just published guidelines on the use of blood-based biomarkers as well as radiology-based or dry biomarkers to assess for chronic liver disease. They were published earlier this year in January and February in hepatology, and those who want to check them out, they're available for everybody without a subscription to the journal itself. But I think that the most respected biomarker for advanced or wet biomarker for advanced liver disease is actually a platelet count, and something that we should pay more attention to. When the platelets are low, liver disease should be ruled out. Clearly, the albumin, the INR are things that we should be paying attention to. Most of us are trained to look at the ALT and AST and the alkaline phosphatase, and those are not necessarily markers of liver function, but of different parts of the liver inflammation. So looking at different aspects of the biochemical assays that we have will help us, help that particular patient. Radiology-wise, I like to start with an ultrasound and probably transient elastography. Again, because it's very cheap, because it's very available, because I can do it in my office. I tend not to do MR elastography or MR PDFF unless the patient has specific needs, because there are issues still getting those tests. I do liver biopsies still, and I do them myself, and I'll reserve that for patients that have diagnostic dilemmas, when I don't know what's going on or when I think that there may be more than one thing going on. And let's go back to that concept of, well, we think that this patient has advanced liver disease. We have this data. Let's talk about the rule of fives and the evolution of transient elastography along with platelet count, telling us that a patient that may have compensated cirrhosis is now at risk for decompensation. Do you want to comment about that?
Yeah, I mean, this is a very important, I would say, new movement in the field. Because in the past, we really separated cirrhosis patients, the component of people that have cirrhosis, into compensated and decompensated. Compensated meaning the patient does have cirrhosis, a cirrhotic liver, but they've not had any complications. Complications are encephalopathy, ascites, variceal bleeding, hepatopulmonary syndrome, some of these less common decompensating events. And the reason we did that was patients that develop those events have a very poor short-term mortality. So it's important prognostically, and it's important if patients are liver transplant candidates to refer them. And in the compensated group, they have very little risk of mortality in the near term, and thus we made this distinction. But probably not nuanced enough. And in recent years, we've had a more nuanced approach now to this. And we've started to separate these cirrhotic patients into different categories because all compensated cirrhotics are not created equally. And it turns out some patients have compensated cirrhosis and do not yet have severe portal hypertension. And other patients have compensated cirrhosis and do have severe portal hypertension. And those patients are at high risk to become decompensated. Not yet decompensated, but soon. And we call that clinically significant portal hypertension. And how they originally defined it was if you do transvenous pressure measurements, which we don't do in practice, the gradient had to be greater than 10.
Right.
Normal is less than 5. In between 5 and 10 is more mild portal hypertension, but not severe enough to have these complications.
Correct.
And that actually has been shown in studies to be predictive of patients that have a worse outcome than the compensated people that don't have clinically significant portal hypertension.
Yeah.
But the challenge has been, how do we actually operationalize that? We don't do pressure measurements on patients. So in practice, we're trying to develop non-invasive approaches to determine if patients have this clinically significant portal hypertension so we can predict better and intervene better to help them have better outcomes. Marcelo, in your practice, how do you use this concept of clinically significant portal hypertension?
Yeah.
How do you measure it in a way that is not invasive, where interventional radiology has to do portal pressure measurements, because we don't do that in practice very frequently?
Mm-hmm. So the guideline talks about using transient elastography and measuring liver stiffness, and we measure that in kilopascals, and combining that with platelet count assessment. So when your transient elastography shows a liver stiffness measurement of greater than 15 and your platelets are less than 110, then you have clinically significant portal hypertension. You go 5 points higher, this rule of fives, if your liver stiffness is greater than 20 and your platelets are less than 150, then you have clinically significant portal hypertension. And then you go another 5 kilopascals. If your transient elastography shows liver stiffness measurement of greater than 25, regardless of the platelet count, you have clinically significant portal hypertension. And again, that is important because that's when we're supposed to act. We're supposed to act by adding a non-selective beta blocker, because these have been shown to decrease the risk of developing variceal bleeding and potentially increase survival in these patients. Not potentially, they have been shown to increase survival in these patients. And of all the non-selective beta blockers, the AASLD now recommends to use Carvedilol. Carvedilol because it has, on top of its beta adrenergic activity, it has an alpha-1 stimulation that causes further reduction in intrahepatic pressures and further reduction in portal hypertension. And the drug does not need to be titrated. You just give 6.25 milligrams twice a day, and that's about it. But, you know, the consensus of the group when we were discussing this in the room was that this doesn't work all the time. And maybe for a third of the patients, they may not be compliant with this recommendation. Maybe for a third of the patients, there's either a contraindication or they don't tolerate the medication well. So many of us are uncomfortable about never looking. Plus, there are some data out there that say that while mortality is not affected by combining a non-selective beta blocker and an upper endoscopy, you can band those patients that require banding, and there will be a lesser likelihood of these patients having variceal bleeding. Having said all that, what do you do in your practice?
Well, I mean, I think in the field of portal hypertension, I think this entire concept and action is one of the most important relatively new developments. It's not something that many of us had thought about when we were training. This clinically significant portal hypertension, where you identify it, and not only do you identify it because it has a prognostic impact, but the action. And the action is using these beta blockers, non-cardioselective, even in patients that may or may not have large varices, like we were taught. And I do that in my practice. I assess patients with cirrhosis For clinically significant portal hypertension, I do use the recommended guidelines in terms of transient elastography measurements and platelet count. And when I think a patient has clinically significant portal hypertension, I do use Carvedilol. I do. Of the non-cardioselective beta blockers, it's probably the best tolerated,
Right.
and it works. The data have been excellent. Works by prevention of decompensation and improving mortality. So very important, and I think it's important for the viewers to really think about this concept, kind of incorporate it into their practice and use Carvedilol. I must say, and this is because of my old-fashioned nature, I do still like to do upper endoscopies on patients. If patients have very large varices, this is my own bent, this is not necessarily a recommendation, very large varices with stigmata that make me worrisome for bleeding, whether they're on beta blockers or not, I actually do band ligation.
Yeah.
Because I think banding in those patients who have very high risk for bleeding helps them. But others don't do that. They put them on beta blockers like Carvedilol, non-cardioselective, and that's all. They don't do the endoscopy routinely to screen for varices because they don't band prophylactically as a primary prophylaxis. So
Recommendations change, and we have some experience. We've been doing this for a while, so we may go back and forth. Hey, thank you for your time, and hopefully this was helpful for our audience. On behalf of Dr. Flamm and myself and the Board of Trustees for the Chronic Liver Disease Foundation, we want to thank all the sponsors that made this Fifth Liver Connect possible and this podcast possible as well. So thank you very much for your support, and we hope that you stay strong for Liver Connect 6.